Hello and welcome to our monthly Kaweah Health Community Engagement webinar. My name is Deborah Volleson. I'm the Director of Community Engagement for Kaweah Health, and I'm joined, of course, by our CEO, Gary Herbst. And we're going to cover several questions that have come in today. We're going to cover our hospital census. We are going to cover some upcoming changes. Some COVID changes are coming to the hospital, and we're going to talk about the financials. We're going to give an update on the dissolution of the partnership with Visalia Medical Clinic and a few others.
Okay.
Gary, are you ready?
Yes, I'm ready.
Okay, so why don't we start with the census?
Okay. Coming at you from early this morning. So I think I've shared with you that twice a day we get an email sharing with us what the census is across every single unit of the acute medical center, as well as all of our other facilities. But I generally just report on the downtown acute medical center. So early this morning at 7 a.m., there was a little bit of elbow room available. We were just slightly more than 89% occupied. Interestingly, our critical care units have had the greatest availability, the ICUs and the ICCUs. But medical surgical beds, we have 237 of them at our downtown medical center. That's where we've been the most impacted. So we had actually 16 of our 41 ICU beds were open, 14 of our 54 ICCU beds were open, but only 13 of our 237 medical surgical beds were open. And that's often why we end up having patients that are admitted, but they're holding down in the emergency department because they really only need a medical surgical bed, and that's where we're most impacted. But fortunately, we only had 7 admitted patients that were holding in the ED this morning, all waiting for one of those medical surgical beds to open up. Much better than the 26 admitted patients that we were holding yesterday morning at this time. So it's really been fluctuating. We love when we see it down in the very low single digits, but we also see days where it's pushing into the 20s and 30s, and it's just very unpredictable. Yesterday's inpatient census, we were at 96% occupancy. So yeah, it's very unpredictable at this point. Monday was a bit of a celebratory moment for Kathy Whitman. Kathy is our infection prevention manager, and she, beginning back on November 1st, officially launches the flu surveillance period. And so she always ends it right around the first day of spring, which I think was yesterday, the 22nd. I know there's 2 different calendars that mark the equinox. But Monday was the final report that Kathy will be sending out for this year's flu season. The flu hasn't completely disappeared. It's still kind of hanging around a little bit, but it definitely has been declining in intensity, as has COVID and RSV. So I'll give you just some of the stats. So for the week that ended March 18th, we had 22 confirmed flu cases and only 1 RSV case. Only 2 of the flu cases actually required that they be admitted as inpatients. And since November 1st, so going back to the beginning of that surveillance period, in this flu season, we have 4,041 confirmed cases of the flu, influenza A or influenza B, and 958 RSV cases. 244 of those 4,000 something flu cases actually required inpatient admission, and of the 958 RSV cases, we admitted 116 of those patients. Although, as I've shared with you in the past, we also transferred many of those children up to Valley Children's Hospital, but also to San Jose Children's Hospital of Orange County, other places. This morning we do have 23 adult COVID patients that are in the hospital, although the vast majority of them are COVID positive, but that's not why they were admitted. So it was running about 50-50 in terms of COVID being the reason they were admitted into the hospital versus a secondary diagnosis. But we've seen that continue to move from that primary diagnosis to just having a secondary diagnosis. And we had one pediatric COVID case in-house this morning. Only one of those 23 adult patients was in the ICU and did not require to be on a ventilator. So we've been consistently, hovering around those mid to low 20s in terms of COVID patients, and the prevalence of COVID throughout our county continues to be at a low level, and so that has led to some changes that are coming up.
Yeah.
I know you're excited about.
Yeah. Oh, yes, I am very excited. But I want to put in a plug. For the ED. We're still holding patients, admitted patients in the ED, and so we're trying to get patients to go to our clinics if they do not have an emergent need. And our social media team put out a post, I'm going to say last week, and it was a graphic shared with them by our community regional medical center in Fresno, asking all hospitals to kind of put this post on, and it has the different categories. If you have this, go to an urgent care. If you have this, go see your primary care physician. And these are the things that would constitute an emergency department visit. So it's a really informative graph. And so we're just trying to push.
That's great.
Yeah. Okay, so back to the exciting news on
Yes.
April 3rd. So tell us about
Well,
that.
I first want to interrupt this broadcast to give a shout out to our production crew, Daniel and Maria. You'd think after doing this probably more than 100 times that I would know to turn my mic on before, but thank you, Maria, I hope I'm coming in a little bit more audible now. So
the questions are really, really loud and the answers are really quiet.
You need to yell, Gary, if you're not going to use your mic. So I don't think anybody has been more excited about the day of April 3rd. Obviously, 2 days before that, April 1st, is April Fool's Day. It also happens to mark my 31-year anniversary with Kaweah Health, but I'm more excited about April 3rd than I am April 1st, because on April 3rd, now we have been informed by the California Department of Public Health that we no longer have to wear masks in healthcare facilities. Not only do our employees no longer have to wear masks, but our visitors no longer have to wear masks either. Unless you're visiting a patient who is in isolation, they either have an airborne disease or a droplet disease or condition, a virus or bacterial that might be emitted into the air. So if they're in isolation and you're visiting them, then you do have to wear a surgical mask. But other than that, we get to throw off our masks and hopefully never to be worn again. That said, I mentioned earlier that the prevalence of COVID in the county right now is low. Should it rise to a medium or high level, then the state's indicated we might have to go back to wearing masks. But all indications are that it's staying low, and so we're very excited about that. Visitors do not have to provide any proof of vaccination, although I don't think we've been doing that for some time now. We still need you to check in at the front desk when you come in, so we will still give you a visitor badge and log you in as a visitor, but again, no longer having to wear a mask. Interestingly, that as healthcare workers, we are still required to be vaccinated or to submit a declination. And the reason is that the federal government, if you receive Medicare or Medicaid funding from the federal government, which all hospitals in California do, then healthcare workers have to be vaccinated. And that means the original 2-shot, Moderna or Pfizer vaccine, or the 1-shot Johnson & Johnson, plus 1 booster. That's to be considered fully vaccinated as a healthcare worker. So unfortunately, New employees that join Kaweah are going to have to continue to get vaccinated or sign that declination or show proof of vaccination until the federal government officially changes their position on that. California is no longer requiring healthcare workers to be vaccinated, but federal law trumps that. So it could be, President Biden has indicated that on May 11th that the federal executive order will be pulled and the disaster pandemic declared officially over at the federal level. So it's possible that on that May 11th date, they may also rescind that vaccination requirement for healthcare workers.
That'd be great. Okay, so moving into another subject, here is the question. Does Kaweah have any influence over doctors' offices in our community? The referral and subsequent appointment is always several weeks or even months out. So is this due to communication and follow-up issues between the clinics and the physicians' offices, or is it due to doctors having limited availability to take on new patients?
Yeah, it's probably multifactorial. I'll first speak to, so we operate 5 rural health clinics in Tulare, Exeter, Lindsay, Woodlake, and Dinuba. We also operate our specialty clinic on the corner of Mineral King and Willis. We have our cardiology clinic out on our west campus. We have a clinic in Tulare on Cherry Street. We have a clinic on Ben Maddox and Tulare. So all of those clinics and the providers, the physicians, the staff are all part of the Kaweah Health system. So we do have direct influence over the availability and the timing of referrals and that whole process. I suspect, though, that this person is speaking more about the private physician community. And with respect to them, we do not have direct influence over those private practices. So with respect to the timing, the availability, that whole process, that's really dictated by that individual physician practice. Now that said, I would say we do exercise indirect influence. We actually have Dee Siebert, one of our physician liaisons, is often out there in the community. That's kind of one of her primary responsibilities, is meeting with physicians in private practice, meeting with their office staff, and she shares with them feedback that we get from community members and from patients. And so certainly, we want to hear that feedback. We certainly want you to give that feedback. And I know there's some frustration. I've experienced it myself. Not always happens the fastest or the smoothest as we'd like. But definitely share that feedback with your provider, but feel free to share that feedback with us as well. I know people reach out to Deborah when they have something with a private practice physician, and so we will reach out to them and we'll talk to them. How can we support them? So that's definitely something we want to hear from you. I would say we also directly influence that referral accessibility through our recruitment efforts. So definitely the San Joaquin Valley, unfortunately, we have some of the lowest ratios of physicians to patients. It's more difficult to recruit physicians to the Central Valley, the San Joaquin Valley, largely because some of the socioeconomic challenges, and there's just not enough physicians across our country, and so it's very, very competitive. Physicians coming out of residency, out of fellowship, have so many different options. They're all heavily recruited, but we've been very successful over the last several years recruiting new physicians to our community, and through that recruitment effort, that then makes more of those specialty referrals, those physicians available. So I think that's probably the way that we can most directly influence the availability and the timeliness of those physician referrals.
Some of the specialties, though, I know in neurology, me personally, I've been waiting on a referral. I think I received the referral in December, and the end of April is my appointment.
Yeah, so we spoke about gastroenterology, neurology, urology, the ologies. Yes, they're in short supply, without a doubt. We do continue to work with Dr. Pantera and other neurologists to explore the creation of our own neurology residency program, because we recognize that it's probably only going to get worse. You know, Dr. Pantera, bless his heart, he retired from private practice, but he continues to provide phenomenal neurology care in our acute medical center. But he will retire someday, and so we really need to start kind of creating our own neurologists. We have increased the availability of urology care through our relationship with the USC Keck School of Medicine Department of Urology, Dr. Indy Gill. We now have Dr. Shiloh Rosenberg practicing in our specialty clinic over on, again, Mineral King and Willis. Dr. Marty Praw, Dr. Joseph Ford. Last night, the board just approved privileges for a renowned urologist that is part of the USC urology program. He is a specialist, so he doesn't provide general urology, but he will be coming here so many days a month to provide this subspecialty care in urology. And we'll be adding more and more of those subspecialty urologists as we start bringing them on staff. And Dr. Gill and USC are actively recruiting for additional general urologists to join Dr. Rosenberg here. So we're working hard. We do need more GI physicians. We definitely need more neurologists. And we'll continue to do everything we can to bring more of them to our community.
So I've gotten this question a couple of times. Have we ever considered, and I don't even know if this is the right term, a geriatric care clinic?
Yeah, it's interesting. Over on Court Street, our 54-bed long-term care facility, which all 54 beds are licensed as skilled nursing, but unfortunately you're aware that we did have to close the 22-bed skilled nursing unit. We still operate the 32-bed subacute unit. But at one time, we actually had a 19-bed geropsychiatric unit. And so that was for elderly patients who were also suffering a psychiatric condition. So they had both a combination of medical conditions that required care in that hospital, at the same time though also suffering from depression, potentially dementia, memory care, other psychiatric conditions. So we've been exploring the idea of perhaps bringing back a geropsychiatric inpatient program. I don't know about the outpatient side, although that's something that we can certainly explore. So about a week and a half ago, we celebrated the grand opening of the Kaweah Health Center for Mental Health, located over on Noble and Encina. That is an outpatient mental health service that is really targeted to the Medicare and commercially insured population, because surprisingly, the Medi-Cal population actually has greater access to outpatient mental health services than does the Medicare or commercially insured population. So like your neurology referral, it takes a long time to get into a therapist. I don't know. I know that they're providing mental health services to the Medicare population. So if that's considered geropsychiatric care for the Medicare population, I know they don't have psychiatrists there yet. That they're starting out with LCSWs and medical social workers, but eventually they will begin adding psychiatrists in the coming months.
Okay. All right, thank you. So the February financials are in, and so somebody had asked, can you give us an update on how we're doing?
Yeah. Well, I think my facial expression just gave a quick answer to it. So February was a 28-day month. 28-day months generally, even pre-pandemic, have not really knocked it out of the park by any means, and give you some perspective as to why. So every single calendar day, obviously Kaweah never closes. We're open 365 days a year. And on average, every single day, we generate about 2.5 million in revenue, actually collected revenue. So not billed charges, but the actual revenue we generate and receive every day. So in a 28-day month, compared to a 30-day month or a 31-day month, just 2 days would be $5 million more in revenue. If it was a 31-day month, that's $7.5 million more in revenue. But our expenses, things like leases for interest, for instance, our debt payments, those are a full month. They're the same amount every single month, no matter how many days are in that month. So lower revenue and really the same expenses. When we talk about labor costs, supplies, medications, things like that, there's only 28 days that are recorded in the month of February for those expenses. But again, a lot of the others, it's the same amount every month. And so generally, February might be a break-even month. Oftentimes could be the only month of the entire fiscal year that we actually generate a loss. But this February, we did have an operating loss of $3.5 million, higher than what we had experienced in December and January, where we'd seen the losses continue to get smaller and smaller. I was telling our employees recently that I can't remember ever in my years here celebrating a loss in a month, but particularly a $2.5 million loss, but far less than the $8 million losses that we experienced in July and August, and then the $12 million loss in September. We did budget a loss for the month. We actually had budgeted a $2.7 million loss for February, so coming in at $3.5 million was a little higher than we had hoped for, but significantly better than this time last year. So for February of 2022, we recorded a $5.7 million loss. So that was, also, we definitely were still experiencing COVID. Hospital was running more than 100% occupancy, more than 200 traveler nurses that we were paying more than $200 an hour. So to go from 5.7 million last year to 3.5 million this year was certainly an improvement, but still, again, a little bit more than what we budgeted. So our fiscal year starts on July 1. So we are now 8 months through the fiscal year. So July 1 to February 28th, and our year-to-date operating loss then now stands at $43 million for the 8-month period. That's higher than an entire year that we experienced back in 2020, 2021, 2022. Those were also all years that we posted operating losses, but just in the 8 months of this fiscal year, it's been the worst. And that's, again, what we're hearing across the country, is that this year, this calendar year 22 and the beginning of calendar year 23 has been the single most difficult year financially for hospitals across the nation. So we're in good company, I guess, so to speak. Just what are the drivers behind that $43 million loss? Just through those 8 months, we've spent $39.1 million in contract labor. Again, that's more than we spent in any of the 3 previous years for the entire year. So we've spent a tremendous amount, $20 million more than what we had budgeted for the first 8 months, and $20 million more than what we had spent last year through the first 8 months. So Fortunately, things are going in the right direction. If I look back to September, that month that we had that $12 million loss, we had over 220 travelers, bedside nurses that were contracted, again paying more than $200 an hour. We're down to 102 contract nurses today, and the rate has dropped all the way down to about $121 an hour. So that is generating millions of dollars in savings compared to what we were spending historically.
Yeah, so people ask questions, and they really don't understand. We're a 24-hour healthcare facility, so we can't just close floors. We can't send nurses home. Why do you need travelers? Why not just shut things
Right.
down? But if we don't have nurse-to-patient ratios, we get fined. What are some other reasons why
Yeah,
we just...
so just earlier today, we had our exec team meeting, and we were talking about staffing, and we mentioned the emergency department in particular. We right now have 9 RN positions that are open, so they're posted. We're recruiting to try to fill them. But to Deborah's point, we can't just run short-staffed. We can't just say, okay, well, we'll just use fewer staff. So that's when we go out and we contract with these nurse travelers, or we pay our own employed nurses an extra shift, or a bonus to work an extra shift, or we pay them overtime. So those 9 positions are still filled, but they're generally filled with very high premium labor costs. Now, there are hospitals across the country that have been closing units, and we talk about it often, that if we really need to wean ourselves completely off of contract labor, and there have been, again, many hospitals have done this. I thought I heard that either Community Regional Medical Center or St. Agnes has taken the position that we don't want any more travelers, and so we will close units if that's what's necessary. And so we have talked about that. Do we close, 3 North? Do we close the Broderick Pavilion so that we can take the nurses on those units and redeploy them to other units where we have travelers and then let those travelers go? The problem is, we cannot go on diversion. We can't say we're not taking any more patients. So what would happen is those patients would keep coming, but I'd have fewer beds upstairs to admit them into. And so they would just, accumulate in the emergency department, in the waiting room. We'd find ourselves, with all of these admitted inpatients. Again, we had 7 today. Yesterday we had 26. Could you imagine if we closed a 34-bed unit? Most of our inpatient units are 34 beds. If we closed a 34-bed unit when we're running, almost 100% occupancy in our medical surgical units, that number would just get larger and larger and larger. Community Regional Medical Center has been reporting, holding 175 admitted patients in their emergency department because they are similarly impacted in their inpatient unit. So, it's really not an option for us, even though it appears to have worked in other places across the country. We also know that a lot of health systems that might have multiple hospitals, maybe in close proximity to them, they've chosen to close those hospitals and consolidate all the patients in a different hospital so they can make more efficient use of their workforce. So again, not really an option for us.
Right, a lot of moving parts.
Yes.
Okay, so you have been very transparent about our finances, articles on a lot of different webinars here, but you've also been slated to be the spokesperson for the California Hospital Association regarding speaking about this publicly to legislators. Right. And so our community engagement groups, they've been along on this ride with you the whole time, from the time your letter went out to staff until today. So the question was asked at one of our meetings last week, does Gary have any regrets about putting himself out there? Because you've taken a lot of scrutiny in the press. We've taken a lot of social media heat. And so that was the question. Do you have any regrets about putting yourself out there?
No, I don't. I obviously I made I made the decision to be transparent, to be honest and forthright with our community, with our providers, with our staff. And that's just how I'm wired. I mean, I've lived my whole life that way. And I definitely, since I became CEO, I made a commitment to the organization and the community to be just that. And I have no intention of being anything different. So I don't have any regrets. I do acknowledge and recognize that I have been one of the more outspoken hospital CEOs in the state, and it hasn't come without a cost, like you've said. I don't want to think that I'm the origin of all these rampant rumors that are running around our community, but I understand them. Yeah, so I walk a fine line. You know, I definitely, it is serious. In fact, I was just reading an email from Carmela Coyle, who's the president of the California Hospital Association. She and I have been, doing this roadshow with the state legislature, federal legislators, the governor's office, and she was sounding the alarm. In fact, what I was pleased to hear about is she was commenting that more than 300 California CEOs have now submitted a letter to the governor and to the entire state legislature and to the California congressional delegation. And that letter is highlighting the financial strife that California hospitals are experiencing, that they've lost $22 billion over the last 2 years as a result of the pandemic. And so while those CEOs may not be out there visibly talking to their community and talking to their employees for fear of scaring them. And again, that's that fine balance. I speak seriously about the nature of this, the unprecedented nature that it is leading to hospital bankruptcies and closures or on the brink of closure, laying off thousands and thousands of employees and closing services. It is that serious. But at the same time, I don't want my employees quitting because they're afraid they won't have a job. And so they go looking for another job. I don't want our community to be afraid to come to Kaweah, that, if they're in such dire financial condition, are they sacrificing safety or quality of care? And I can assure you that we are not. But I do recognize that these rumors are out there. It's why I published an article we call News You Can Use, and then I followed up with a video that I recorded that we're trying to get out to everybody that emphatically states, and this is the absolute truth, we are not filing bankruptcy, we are not closing, we are not being taken over by another hospital or health system. Adventist Health, Community Regional Medical Center, they are not taking us over. We are on our road to recovery. We're coming down this path. We got some good news just recently that working with Congressman Jim Costa's office and Kevin McCarthy's office, 3 of our 4 FEMA applications have now been approved. We have one big one for $12 million that we are looking to be approved, and that's being evaluated right now, reviewed by FEMA. So that will be a nice injection. We've been working very closely with Senator Shannon Grove's office, and she remains very optimistic that our ask of the governor to infuse $1.5 billion into as a one-time kind of financial lifeline to California hospitals to put it in his fiscal year 24 budget, that's looking more and more promising. So I'm very excited about that. We will learn more in May when the governor releases his what's called the May revise. It was not in his initial January budget, but these letters, 300-something CEOs sent letters to all these folks. It's easier to send a letter rather than publish it or talk about it, publicly. But I'm still grateful that so many hospital leaders have, brought our voice together. So that gives me a lot of hope and optimism. And if that comes through, then that will be a huge boost to Kaweah. I've told our folks that our future is not dependent on that happening. We're not relying on it. The actions that we're taking are paying off, and they will get us back on our feet. It will just take longer to recover. So if we got that infusion from the governor and the legislature, that would certainly accelerate our recovery and getting back on our feet.
Yeah, great. Has he responded to any of the 300 CEOs?
Well, he hasn't responded to me. If he responded to all the rest, then good for them. I don't need to be recognized in that way. I just want to see the results.
I would really just love for him to respond, because our community asks that every time. Has he responded? Has he responded? So
not yet.
No. Awesome. Okay, so here's a question. Why is Kaweah spending money on advertising when they are losing money?
Yeah, no, it's a great, understandable question, and I think my answer has been very, very consistent. Our financial road to recovery, our plan is a balanced plan. So it is one that is about revenue growth as well as cutting costs. And so you really need to do both. In fact, if I had my preference, I would always rather grow my way back into prosperity than to cut my way back. So it's much more painful to have to, lay off staff and close services and cut salaries, and like we've had to do. But at the same time, I want to grow revenue too, and then that means advertising. We do, certainly enjoy a very large market share for healthcare services in our community, but you'd be surprised by the number of people that leave our community to maybe go have back surgery because they don't know that we provide neurosurgery here, that our neurosurgeons are part of the USC neurosciences faculty, or that we're rated number 2 in the state of California for open heart surgery. They may not know that. And so advertising is about, is raising the knowledge and the awareness of the Kaweah services within our community so that folks will use our hospital and receive our outstanding care, renowned, recognized care, instead of going to Fresno or going to the Central Coast. So that's advertising is part of that revenue growth strategy. It's also, while you'll continue to see us open that Center for Mental Wellness, that's projected to be a profitable service. We're developing a clinic out in the industrial park that'll really focus on occupational medicine, pre-employment screenings, walk-in services, as well as scheduled. A lot of growth and development going on in Northwest Visalia, and certainly a lot of businesses coming into the industrial park that are very excited that we're going to have a clinic there that's available to their workforce. That will also be a very profitable service. So you'll continue to see us, probably not doing much on a grand scale, but where we can, a lot of things we're doing too, particularly in the mental health. We just closed escrow on the old Boy Scout building in North Visalia. That will become a child and adolescent crisis stabilization unit. So that is being entirely funded through a grant received from the state. And then we will soon embark on building a 22-bed wing affixed to our mental health hospital on the West Campus that also is for children, child and adolescent inpatient psychiatric unit. That was entirely also funded by a grant from the state. And the operation of we expect both of those services to be very profitable because they're in very high demand, very limited availability even in the state. But that crisis stabilization unit, that's actually a partnership with Tulare County. And so they will help fund the ongoing operations of it. So all of those services are projected to generate additional revenue and profitability that also helps on that recovery plan.
Okay, thank you, Gary. So can you give us an update on Visalia Medical Clinic and where we are in that process?
Yeah, so we continue to work very closely with Visalia Medical Clinic leadership, and now we're working very closely with Adventist Health leadership. We've now met with Adventist Health representatives on a number of different occasions. Had a good meeting with them just about a week and a half ago that I also attended. They have pushed the target date of the transition from March 31st to April 30th. So it will now be April 30th where the transition from Kaweah Health to Adventist Health will occur. I'll just remind folks that Visalia Medical Clinic is currently an independent physician-owned medical group, and it will remain an independent medical group in that it has its own board of directors, it's owned by the doctors, but instead of having a professional services agreement with Kaweah Health to essentially own and operate its clinic services and practices, that agreement is ending, and they are entering into a new agreement with Adventist Health. And it's actually with our respective medical foundations. So Kaweah Health has a California medical foundation that VMC contracts with, so does Adventist Health. So that they essentially will just step into the same role that we had with Visalia Medical Clinic. So that transition is moving along. Just to remind folks, so that the foundation clinic located on Cherry Street in Tulare and the foundation clinic located on Ben Maddox in Tulare, they're called Kaweah Health Medical Group, which is the name of the medical foundation. So on April 1st, those two clinics will be reverting back to ownership and operation by Kaweah Health. I'm excited to announce Dr. Sarmad Saeed, an outstanding interventional cardiologist that has been working in that Cherry Street clinic in Tulare. He has made a decision that he wants to remain with Kaweah Health, so he will not be joining Adventist Health. He will be staying with Kaweah Health, and so his practice there in Tulare will continue to operate in an uninterrupted fashion. And so we're excited about that. Now, how will this impact the patients of Visalia Medical Clinic? I still don't know the answer to that. I think that's still, to be determined. We have many of our own employees and their covered dependents under our employee health plan that utilize Visalia Medical Clinic physicians, primary care, pediatricians, their specialists. And so we've told our employees that you will continue to be able to receive care from all those same Visalia Medical Clinic physicians. You will pay the same, $20 copay that you pay now when you go to see your family medicine physician or your pediatrician. What will change, though, is if you are referred to an Adventist Health hospital or an Adventist Health ancillary service, like you need an MRI or a CT or lab work, or you need to be hospitalized or have outpatient surgery. So if one of our employees or their covered dependents is referred to one of those Adventist Health facilities instead of a Kaweah Health facilities, then our employee will pay a higher out-of-pocket expense. So that's the case for our employees. I don't think that'd be the same case for our community members, because Adventist Health pretty much contracts with all the same health plans that Kaweah Health contracts with. So if you go to Visalia Medical Clinic through your coverage with Medicare, or say one of the Medicare Advantage plans, or you're with Anthem Blue Cross or HealthNet or Blue Shield, I suspect that Adventist Health holds all those same contracts. And so you'll be able to continue to go to Visalia Medical Clinic, and your services will be billed to one of those health plans. What we don't know is, where you might receive all of your hospital care and those ancillary services from Kaweah facilities, will you now be referred to Adventist facilities? Because the clinic essentially is owned and operated by Adventist Health, who has hospitals in Tulare and Hanford, Selma, Reedley, Bakersfield. They also have, outpatient imaging centers and laboratories and ambulatory surgery centers. And so will you be referred to those facilities instead of Kaweah facilities? I think for us, that's the big unknown. I think that's what causes us the greatest concern. The leadership at Visalia Medical Clinic has assured us that their physicians will continue to use Kaweah facilities as they do now. Ultimately, it's always the physician and the patient's choice. Physicians will generally refer or take their patients to the facilities that they want to provide the service in. And definitely you as a patient have a lot of say in where you receive those services. So I think that's really the only thing that's kind of up in the air, and only time will tell how it will affect patients in our community.
All right, thank you, Gary. Well, we have covered all the questions, and look at that, we've got a few
yeah.
minutes to spare.
That's so unlike me, huh?
We can always count on you to use the whole hour.
Yes.
That's for sure.
Yes.
But let's close it out.
Yeah, just again, we've been doing this now for 3 years,
For
3
3
plus
years.
years.
Yeah, 3 plus.
Yeah, and I will tell you, it's been a delight. It's been one of those silver linings of the pandemic. I don't think we were doing town hall meetings before the pandemic. That was something really new for us. But this certainly accelerated that and elevated our outreach to the community, and to be able to have this ongoing dialogue and answer your many questions. And so I guess a little after our 3-year anniversary, I'm not celebrating it, but I am recognizing it. I just want to again express on behalf of our organization and all of us, just want to express our appreciation and gratitude to all of you for sticking with us over these 3 years. And many of you have actually been working with us since 2017, when we launched our community advisory committees and our community engagement initiative. So it's been very rewarding, I know, for Deborah and myself, and Daniel and Maria have been here all the way with us as well. And so I think this is really a permanent part of our communication efforts with our community, and we certainly hope to expand it over time. I think last week we had over 150 people that watched this on YouTube or something like that. So we're still impacting our outreach, and would certainly encourage you to tell a friend. We're not just limiting this to just people that are formally a part of our community engagement initiative, but we really invite anyone from our community to tune in or submit our questions. Again, we've made a commitment to be your source of truth, and to hopefully reduce the amount of misinformation and disinformation that's out there. So just want to wish you all a great week, a great weekend. Looks like the skies have dried up a little bit. So be safe there. I know it's a little challenging right now for our county, and our thoughts and our prayers go out to our community members that have been hit by this unprecedented, or probably not unprecedented, but rare amount of rain and snow and everything that we're experiencing in the towns of Allensworth and Alpaugh, and our thoughts and prayers are with all them. So thank you, and have a great day.